today, trachea, lung, and bronchopulmonary segments. Trachea is a tube. The trachea is a tube-shaped structure 15 cm long and 2 cm in diameter, made up of 15 to 20 incomplete ring of cartilage that are bridging posteriorly by the trachealis muscle. The trachealis muscle encircles the trachea completely, but it's most prominent posteriorly due to lack of cartilage. This is the trachea, and this is the tracheal cartilage. It's begin at the lower border of the cricoid cartilage at the level of the C6 vertebra, and extend to the carina at the level of the sternum angle, T5 level, T4 on inspiration, and T6 on expiration. In children, is very pliable, deviated to the right at almost 90 degrees in normal expiratory film. It's only deviated to the left if the aortic arch is on the right side. This is the trachea extended from the cricoid cartilage at the level of the C6 to the carina at the level of the T5. The relation of the trachea. On the cervical region, anteriorly, isthmus of the thyroid, anterior to the second, third, and the fourth rings, inferior thyroid veins, and the strap muscles, sternohyoid and the sternothyroid. Posteriorly, esophagus and the recurrent laryngeal nerves. Laterally, lobes of the thyroid gland and the common carotid artery. This is the trachea, this is the thyroid isthmus, and post-thyroid lobe, this is the recurrent laryngeal nerve. On the thoracic region, anteriorly, brachiocephalic and the left common carotid arteries, left brachiocephalic vein, posteriorly, esophagus and the left recurrent laryngeal nerve. On the left lateral, arch of the aorta, left common carotid and the left subclavian arteries. On the right lateral, right brachiocephalic artery, right vagus nerve, arch of the azygous vein, pleura in direct contact, unlike the other side. This is the trachea, this is the esophagus and left recurrent laryngeal nerve. This is the aortic arch, left common carotid artery, and right common carotid artery. Right paratracheal strip. The lung is in contact with the trachea from the level of the clavicle to the azygous vein in the right tracheobronchial angle. As the trachea is air-filled, the right tracheal wall is seen as strip, which should not measure more than 3 mm. The left tracheal wall is separated from the lung by the aorta and the great vessels and is not seen. By X-ray view, frontal view show the right paratracheal strip. This is the right paratracheal strip. The posterior tracheal strip. The posterior tracheal strip or line is formed by air in the trachea and air in the right lung, outlining the intervening posterior wall of the trachea and soft tissue. It's seen on the lateral chest X-ray and normally measure less than 2.5 mm in width. Abnormal thickening has a variety of causes. The most common is congenital or acquired aortic arch abnormalities and esophagus pathology such as malignancy, dilatation, diverticular, duplication cyst, mediastinitis, and mediastinal hematomas. The posterior tracheal strip can also normally appear thickened, measuring up to 5.5 mm, and then called the tracheoesophageal strip. This is the lateral X-ray. This is the posterior tracheal strip, and also part from the axial CT scan. This is the strip. Lateral chest X-ray. The trachea is seen to enter the thoracic midway between the sternum and the vertebrae. Owing to some posterior inclination, it's the end closer to the vertebrae. The left mini bronchus, being more horizontal, is seen as circular structure. The right mini bronchus is more vertical and is therefore tubular on this view. This is the trachea, this is the right bronchus and the left bronchus. Blood supply. The upper part is supplied by inferior thyroid artery, which is a branch from the thyrocervical trunk, which is a branch from the subclavian artery. The lower part is supplied by the branches of the bronchial artery. The venous drainage is to the inferior thyroid venous plexus. This is the inferior thyroid artery. This is the superior and middle bronchial artery. This barium meal shows H-type tracheoesophageal fistula, which is a rare type of fistula between the trachea and the esophagus. Mini bronchi. The carina, it is anterior-posterior ridge at the junction of the mini bronchi. It lies T5 vertebral level, T4 on inspiration and T6 on expiration, and at the level of the sternal angle. The carinal angle measures approximately 65 degrees, that is 20 degrees to the right of midline and 40 degrees to the left. This angle is slightly larger in the children. The carinal angle increased by 10 degree to 15 degree in recompensa. Widening of the carinal angle on the PHS radiograph above the 65-degree marker of enlargement of the left atrium indicated mitral valve dysfunction, either stenosis or incompetence. This is the carinal angle. This is the median plane, 20 degree to the right from the medial plane and above the 35 degree to the left from the median. Right mean bronchus and atrial bronchus. The right mean bronchus lies at about 25 degree to the median plane. It is 2.5 cm long and 1.5 cm wide. That is wider, shorter, and more vertical than the left mean bronchus. The relation of the right mean bronchus are as follows: anteriorly, superior vena cava and right pulmonary artery; posteriorly, azygous vein; superiorly, the arch of the azygous vein. This is the right mean bronchus. This is the secondary bronchi and the tertiary bronchi and the bronchiole. Upper lobe bronchus arise almost immediately after tracheal bifurcation, entering the hilum of the lung separately and thereafter dividing to the anterior, apical, and posterior. The right bronchus continue as bronchus intermedius, which then divided into the middle and lower lobe bronchi. The middle divided into the medial and lateral. The lower lobe bronchi. The apical segmental bronchus of the lower lobe come off opposite the bronchus to the middle lobe. The lower lobe bronchus divided into 4 basal segment bronchi: posterior, lateral, anterior, and medial. This is the upper lobe bronchi divided into upper, posterior, and apical, posterior, and anterior. And the middle divided into the lateral and medial, and the lower lobe bronchi divided to the superior, medial, lateral, anterior, and posterior. Left mean bronchus, hyparterial bronchus. The left mean bronchus lies at 40 degree to the median plane. It is 5 cm long and 1.2 cm in diameter. The relation of the left mean bronchus are as follows: anteriorly, pulmonary trunk; posteriorly, esophagus and the descending aorta; superiorly, arch of the aorta and pulmonary artery. This is the left mean bronchus. Left mean bronchus divided into the upper and lower lobe bronchi within the lung. The upper lobe divisions are similar to the right. The posterior and apical segmental bronchi usually have a common apico-posterior bronchus, which then subdivided. The lingular lobe bronchus come off the upper lobe bronchus and has superior and inferior divisions. The lower lobe bronchus has apical, lateral, anterior, and posterior basal segments, but no medial basal segments. This is the upper lobe bronchi. This is divided to anterior and apico-posterior, which is divided then to the apical and posterior. This is the angular part divided into the superior and the inferior part divided to the superior, anterior, lateral, and posterior. The X-ray view frontal show the site of the trachea, left mean bronchi, right mean bronchi, the carinal, and the aorta. On the axial CT scan, we have the 3 important levels: at the level of the trachea, at the level of the carina, and at the level of the heart ventricles. At the level of the trachea, we show the right upper lobe and the left upper lobe. We show also at the level of the aorta, we show the right upper lobe and right lower lobe. Left upper lobe. And also at the level of the carina, we have part from the right upper lobe and right lower lobe and the medial part of the middle lobe. And also on the left side, left upper lobe, left lower lobe, and the inferior part of the lungula. At the level of the ventricle, we have right lower lobe and the medial part and the middle lobe, and also left lower lobe and the inferior part of the lungula. This is coronal CT scan, show the trachea, left mean bronchus, right mean bronchus. This is the apical segment bronchus of the right upper lobe and the right lower lobe bronchus. This is the major fissures. The blood supply, whereas the lung receives the entire output of the right heart, their own nutritive supply arises from the bronchial arteries, branches of the thoracic aorta. The bronchial veins drain on the right to the azygous system and on the left to the hemiazygous system. This is the aortic arch, this is the thoracic aorta, the bronchial arteries, two to the left and one to the right. It is lies at the level of the T5 or T6. The lungs. The lungs are described as having costal, mediastinal, apical, and diaphragmatic surfaces. The right lung has 3 lobes and the left has 2, with the lungula of the left upper lobe corresponding to the right middle lobe. One terminal bronchiole with the lung tissue forming a sinus, which together with the vessels, lymphatic, and nerves form the primary lobule. 3 to 5 primary lobule form secondary lobule. This is the right lung. This is the apical, costal, and diaphragmatic surface, upper, middle, and lower lobe divided by the oblique and transverse fissure. This is the left lung divided by oblique fissure to the upper and lower lobe. Lung roots. It is formed by structures that enter and emerge at the hilum. They lie at the vertebral level T5 to T7. The right lung root lies below the arch of the esophagus vein and posterior to the superior vena cava and right atrium. The left lung root lies below the arch of the aorta and anterior to the descending aorta. This is the right lung. This is the root. It lies inferior. This is the esophagus vein. This is inferior to the arch of the esophagus vein and posterior to the superior vena cava. And also on the left lung, the root lies inferior to the arch of the aorta and anterior to the descending aorta. The right pulmonary artery lies anterior to the bronchi, and the right pulmonary vein lies anterior and inferior to the artery and the bronchi. The left pulmonary artery lies superior to the left mini bronchus, and the left pulmonary vein lies anterior and inferior to the left mini bronchus. This is the right lung. This is a groove for the esophagus vein and the arch of the esophagus, and this is a groove for superior vena cava. This is the right lung root. This is the mediastinal surface. This is the groove for the arch of the aorta and the descending aorta. This is the root of the left lung. The lymphatics. Firstly, pulmonary nodes in the lung tissue. Then bronchopulmonary node, carinal node, and tracheobronchial node above the tracheobronchial junction, and right and left paratracheal node, and then finally drain the bronchomediastinal trunk. Lung fissures are double fold of visceral pleura that either completely or incompletely invaginated lung parenchyma to form lung lobes. The oblique major fissure, the transverse minor fissure, the accessory fissures. Oblique major fissure, this is similar in both right and left lung. It's extended from the T5, T4, T5 posteriorly to the diaphragmatic anterior-inferiorly. The left major fissure is more vertical oriented than the right. The fissure do not follow a straight plane from the top to bottom, but are undulating in their course. The medial aspect of each fissure passes through the hilum, while the lateral aspect of each fissure is anterior to the medial aspect at the level of the hilum and below. Above the hilum, the relationship change, and the lateral aspect of the fissure is more posterior than the medial. This is the sagittal CT scan. This is the oblique major fissure and minor fissure. This is and lower lobe. This is the left lung with upper and lower lobe. This is the oblique fissure. This is axial CT scan, show major fissures and minor fissure. Fissures on the lateral X-ray. The left oblique fissure. معروف صوتي واضح؟ Fissures on the lateral chest X-ray. The left oblique fissure is more vertical and more posteriorly than that on the right. The left oblique fissure is at an angle 60 degrees to the horizontal, and the right at an angle 50 degrees. The anterior end of the oblique fissure are 2 to 3 cm behind the anterior chest wall. Occasionally, the upper end of the oblique fissure may reach T3. As the fissures are undulating, they may appear to be doubled in parts and are often not seen in entirety. For the same reason, the posterior part of the transverse fissure may be occasionally seen to cross the right oblique fissure. This is lateral X-ray. This is the transverse fissure and oblique fissures. This is the aortic arch and tracheoesophageal strip. Transverse minor fissure. This separated upper and the middle lobe of the right lung. It runs horizontally from the hilum to the anterior and lateral surface of the right lung at the level of the fourth costal cartilage. Its posterior limit is the right oblique fissure, which it meets at the level of the sixth rib in the mid-axillary line. It's anatomically complete in only 1/3 of subject and is absent in 10%. The transverse fissure of the right lung identified in 50% of PA radiograph and about 80% in dissection specimen. By X-ray view, this is the horizontal fissure lies between the upper and middle lobe, right lobe. Pulmonary, this is the patient presented with done X-ray for him. PA and lateral show loculated fluid collection on the transverse fissure. This is occur mostly in patients with congestive heart failure. This is called pulmonary pseudotumor. This X-ray view show bulging fissure sign. This is important sign in patient infection with Klebsiella Friedlander pneumonia, also transverse fissure. This X-ray view and coronal CT scan for patient have upper lobe, right upper lobe bronchus obstruction, show lung lobe collapse with the transverse fissure pulled up. This is called golden S sign. If the obstruction occur in the left upper lobe bronchus, this is called loftical sign. This is appear and also this is in coronal CT scan. Accessory fissures. Firstly, the azygous fissure. This is downward invagination of the azygous vein through the apical portion of the right upper lobe. It therefore has 4 pleural layers, 2 visceral and 2 parietal. The term azygous lobe is inappropriate as there is no corresponding change in lobar architecture. Azygous fissure is found in 1% of postmortem and seen in 0.4% of radiograph with teardrop shadowing of the azygous vein in its lower end. This is the course of the azygous vein. This is to be draining finally in the superior vena cava. This is the azygous fissure. This is the azygous lobe. This is X-ray view, frontal X-ray. This is the azygous fissure. This is the azygous vein and the azygous lobe. Also by axial CT scan, this is the azygous lobe and the fissure. Superior accessory fissure. This separated the apical segment of the right lower lobe from the basal segments. It lies parallel and inferior to the transverse fissure and passes posteriorly from the right oblique fissure to the posterior surface of the lung. Superior accessory fissure identified in 5% of PA radiograph. This is sagittal CT scan shows superior accessory fissure. This separated the apical from the basal segment of the right lower lobe. It is also lies parallel to the minor fissures. Inferior accessory fissure, the other right lower lobe segments called Twenning's line. It is seen in 30 to 50% of most mortem examination. Inferior accessory fissure identified in 8% of PA radiograph and about 20% in high-resolution CT scan, 30 to 50% in anatomical dissection. This is the inferior accessory fissure. Separate the medial part of the lower lobe, right lower from other parts. The left transverse fissure. The left transverse fissure separated the lingular segment from the remainder of the upper lobe. It's seen in 2% of PA radiograph, 9% in high-resolution CT scan, 18% in anatomical dissection. This is the left transverse fissure. Fissures on the CT scan. On conventional CT scan, fissures are less visible than on PA radiograph. They are seen as region of relative avascularity on the outer cortex of the lobe, where tapered vessels are less visible. This is the transverse, oblique, and the oblique fissures, upper, middle, and lower lobe. Pulmonary trunk. Pulmonary artery conveys venous blood from the right ventricle of the heart to the lungs. It is short, wide vessels about 5 cm length and 3 cm right ventricle. By CT scan, this part from axial CT scan. This is mean pulmonary artery, the right pulmonary artery, the left pulmonary artery. This is the ascending aorta and the descending aorta. This is by contrast, CT with contrast. Right pulmonary artery is longer than the left. It passes across the midline below the carina and come to lie anterior to the right mean bronchus. It's bifurcated while still in the hilum of the right lung. An artery for the right upper lobe passes anteriorly to the right upper lobe bronchus. The interlobar artery to the right middle and lower lobe pass with the bronchus intermedius. This is the right pulmonary artery with a segmental artery, with its segmental arteries. The left pulmonary artery spiral over the superior aspect of left mean bronchus to reach its posterior surface. It's attached to the concavity of the aortic arch by ligamentum arteriosum. It's further subdivided into the segmental arteries that travel with the segmental bronchi, for the most part on their posterolateral surface. The pulmonary arteries supply only the alveoli, the bronchial arteries, which supply the bronchi. Also, this is the left pulmonary artery and its segmental arteries. Pulmonary veins. The pulmonary veins do not follow the bronchial pattern, but tend to run in intersegmental septa. Two veins pass to each hilum from the lung tissue above and below each oblique fissure. These enter the mediastinum slightly below and anterior to the pulmonary arteries. On the right side, the vein from the lobe may remain separated so that 3 veins leave the right lung and enter the left atrium, while on the left side, the 2 pulmonary veins may unite and enter the left atrium as single vessels. This is the right pulmonary vein and the left pulmonary vein. This is the pulmonary trunk. This X-ray, this is the frontal X-ray, show the trachea, the carina, its right hilum and the pulmonary artery, and also left hilum and pulmonary artery. This is axial cardiac CT scan with intravenous contrast, show the mean pulmonary artery, the right pulmonary artery, left pulmonary artery, the right superior pulmonary vein, the superior vena cava, and the ascending aorta, and also ascending aorta. Hiller point is where the upper loop vein across the descending pulmonary artery. The right Hiller point is projected over the 6 posterior interspace and 1 cm lower than the left. Both Hiller should be concave and of similar density. The Hiller angle is the angle between the vessels at the Hiller point and is normally 120 degrees. This is the side of the Hiller point and Hiller angle. The hidden areas. We have multiple hidden areas. The apices, both the Hiller, retrocardia, and both diaphragmatic. Check the apices for pneumothorax tumor and the cervical rib, and also check both Hiller and compare Hiller position, density, and morphology. Check the AP window, assess the ascicus contour, and the border of the cardiac and both the diaphragmatic. Vascularity on the lateral chest X-ray. The pulmonary artery may be seen at the hilum forming conglomerate density with the pulmonary veins. The right pulmonary artery is seen end-on and is oval in appearance. The left pulmonary artery is comma-shaped as it is arched over the left mean bronchus. They may each measure up to 3 cm in diameter. The confluence of the pulmonary vein is seen below the oval density of the right pulmonary artery on the lateral film. The superior veins are more anterior than the inferior pulmonary vein. Bilateral X-ray, this is the side of the pulmonary artery. This is the ascending aorta arch and descending aorta. Pulmonary angiography. A catheter inserted via the femoral vein to the inferior vena cava, right heart, and the pulmonary trunk. The pulmonary trunk inclines posteriorly as it is leaves the heart and is best seen when the beam is angled 45 degrees to the anterior chest wall. Bronchial angiography. This is used and embolic treatment of the hemoptysis. The bronchial arteries are catheterized from the thoracic aorta if they arise from it. Owing to variable origin of the bronchial arteries, it may be seen necessary to catheterize the subclavian, internothoracic, or intercostal arteries. As the spinal arteries also arise from these results, there is risk of spinal ischemia by using this procedure. The MRI. Because the lungs are very low proton density and move with respiration, they are poorly seen by this method. يعني احنا اختصرنا الام ار اي استخدموها يعني اكثر شيء ام ار انجيوغرافي. Isotope ventilation, perfusion scanning. A ventilation scan outline the trachea and mini bronchi in addition to the lung. A gap is seen owing to the mediastinum and the cardiac notch is seen in the anterior border of the left lung. Perfusion scanning may show differential isotope distribution from the apex to the diaphragm owing to the variation in the blood flow associated with this posture. Quiz.
يلا اوكي بقى. محمد حسن شكر.
نعم أستاذ. This is the horizontal fissure of the right-sided horizontal fissure.
اوكي. فرح زهير.
نعم أستاذ. This is azygous fissure.
التأشير على اللاين اللي هو الفيشر، بينما
نعم.
إذا كانت على النهاية هو الفين. الزايغس فين. إيه بالضبط. عندنا سماء عطية.
نعم أستاذ. This is bronchus intermedius.
برونكس انترميديس مؤشر على ورا سماء عندنا سؤدد سلمان دي.
نعم أستاذ. دي anterior segmental pulmonary artery.
anterior segment of the pulmonary artery. اوكي. أستاذ محمد.
عين أستاذ رعد وياكم.
يلا كمل وياهم.
ايه ياسمين.
نعم أستاذ. anterior junctional line.
نعم.
anterior junctional line.
زين. عزام.
نعم أستاذ. دي ascending aorta.
ascending aorta. زين. محمد خضير.